Thank you, sir. I'll be talking about my approach to Excel macular holes. Giant macular holes is defined as base diameter of more than 1000 microns and minimal diameter of less than 800 microns. These holes have high rate of failure at the rate of 19 to 24% in Manchester large macular hole study. If you look at the recent classification based on the size of the macular hole, what we are going to deal is excess large macular hole, that is 800 to 1000 microns, and giant macular hole, that is more than 1000 microns. If you look at the management strategies which has been described in literature is autologous retinal transplantation and human amniotic membrane for XX large macular holes and giant macular holes. But the problem with retinal grafting is the vision does not improve. There's no function was detected by microperimetry in the region corresponding to the foveal center. We cannot say how, if you put in retinal graft, how this retinal graft is going to integrate with the existing retina. In amniotic membrane, improvement in vision is doubtful. So we go for a newer concept, what we call as an plug and detach. In this, the scaffold or the ileum inverted flap provides an scaffold. Retina is made elastic by detaching it in the macular arcades. Advancement of macular tissue by increasing the elasticity of the retina by ILM peeling. Scaffold over the macula. Macular detachment results in improvement in vision in all our cases. So how it is different from original hydrodissection technique which was described by Filfili et al. In retina. He did not use inverted ileum flap as a scaffold. Technique was, what he used was through the macular hole, he lies the attachment between the RPE and the retina. But in our technique, what we are doing, we are detaching whole of the posterior pole so that there is an advancement of the retina. If you look at this patient, if you see the size of the macular hole, it is 1100 microns. And you can see, if you see the macular hole parameters, this hole is not going to close with the conventional technique. So we took this patient for surgery, and after injecting BBG dye, we had a stain. And what I do is I create a rip in the ileum almost 360 degree. And by creating a rip, I don't lose this ileum and I get an saucer-shaped ileum, which is almost similar in all diameters across the macula. You can see this rip is created almost 360 degree. And once this rip is created, I use an Eckhart forceps to pull this ileum till the edge of the macula. I will not go across the macula, but I will just peel this ileum till the edge of the macula. See, I am going till the edge here. Similar maneuver is done from all the side so that I get an adequate relaxation by peeling the ileum. And once this is done, I reduce my suction from 400 or 500 to somewhere around 70, because if you use high suction, you can pull this ileum flap, and this ileum flap is then trimmed at a low suction. A 23 gauge needle with 38 gauge tip is used to create a detachment of the posterior pole. And you can see the detachment starts with the blister here. And you have to keep on injecting till this detachment reaches the macula and you see a fluid coming out from the macula. One area of detachment will not result in closure, so you have to go ahead and do detachment in multiple areas or at least 2 areas. So once the detachment is created in this area, I go between the disc and the macula and create a detachment. You can see the fluid coming out. And once the fluid comes out, I know my whole of the attachment of the retina through the RPE is not there. And then fluid air exchange is done, and you can see the post-op results. You can see there is an almost type 1 closure. This patient improved to 636. This is another patient, this was my first patient with macular detachment. Uh, there was an PFCL bubble also. So I went ahead and did a similar procedure. After doing the graft, I aspirated this PFCL bubble from a 38 gauge needle, and from this I again created detachment at the posterior pole. The mistake what I did is ki, if you go in the opposite direction, you will not create a detachment into the macular area. What you are doing here is ki you are creating detachment into the infratemporal area. So the fluid direction should be towards the macular hole. So if you are on the right eye, you have to create a detachment between the disc and the macula so that the macula gets detached. You can see the post-operative picture here. This is a type 1 closure, vision improved to 636. Some other patients with square macular hole, you can see this patient type 1 closure, 612 vision improvement. This is a large traumatic macular hole. This was a child. I went ahead and did a similar procedure in this and put a silicone oil. This patient improved to 618. These are my results of 9 patients which I created a macular detachment, and you can see in almost all the patients vision has improved at least by 2 to 3 line. One of my patient failed because I didn't get an ILM as in scaffold. I used glue as a scaffold, and this patient failed here. So various technique has been described for failed and recurrent giant macular hole, inverted flap, autologous ILM transplant, lens capsule transplant, neurosensory retinal graft, amniotic membrane graft, retinotomies, and hydrodissection. Up to 39% of chronic macular hole has been reported to have adhesions between the retina and the retinal pigment epithelium, contributing to difficulty with the hole closure. This gives a square-edged appearance on OCT in contrast to puckered edge seen in acute macular hole. So we try this technique which results in closure and plus improvement in vision. The basic concept is if you put in retinal graft, integration will not occur. But if you have an pediculated graft here which has a blood supply, which has a neuronal connection, the vision will improve in these patients. Procedure like retinal, there is no metamorphosia in this technique vis-a-vis retinal graft. But the problem is I have done only 9 cases, but all of my cases has improved. So to conclude, plug and detach is effective technique in giant macular hole. There is a definite improvement in vision as same retinal tissue is advanced. In this case, harvested autologous retinal graft is an ischemic scaffold tissue causing anatomical closure, will not give any kind of functional improvement vision. You will be happy seeing the OCT key hole is closed, patient will be happy, but vision improvement does not occur. Thank you very much for your kind attention.
Thank you, Avnindra.